anticipatory guidance topics and asked if, like, what's the one that the nurse would want to make sure for sure we covered. And that was based on Maslow's, because there was a safety one, and then there was like a psychological, emotional growth and development. So obviously safety is gonna come before that. But you should generally know, because this goes along with primary safety concerns and teaching, that's hand in hand with our anticipatory guidance. So that's a good question. What are some safety concerns for the preschool age group? Choking. What else? Car seat safety, definitely. Water safety. Poisoning. Why poisoning? They don't have a very discriminating sense of taste. But car seat safety, also remember in the preschool age group, this is a lot of time kids are growing out of their 5-point harness car seat and growing into their next version of car seat. So then what would we counsel? Weight. Yeah, so every individual manufacturer has a height and weight requirement that you're not supposed to go past for the car seat, so you have to check the car seat for that. But say they've grown out of that, then what do we put them into? What are we looking for in the preschool age group? Yeah, a booster seat, it can be with a back or not, but the main concern is that it's a belt positioning. So it puts them up high enough for the lap and shoulder belt to come across their shoulders and chest and not across their face and neck. So again, especially here in Arkansas, everyone's in a car because we don't have good public transport like we might in bigger cities. So those are the kind of things that I wanted y'all to focus on that component. But if I were asking you, like, if you're like, oh, these are all right, which one do I really super need to teach? Well, always fall back. If at any time we're asking y'all to prioritize, remember those frameworks for ATI. Is this can I make it fit on Maslow's? Is there a safety versus well, that's an emotional growth thing or a spiritual growth thing, which are nice. We want to get there, but we have to be safe to do those. Or is it acute versus chronic? Those kind of things affect everything. Good question. Brian, you said, what did you say, how many questions? Do we have a final count? I think we're 49. 49.
Are you showing? I have a question on the chat. Can't find the lymph node names areas with what type of infection they are most associated with.
Okay, so we focused on the lymph nodes of the head and neck, if y'all will remember that, although you do have lymph nodes all over your body. So for one thing, I just want to throw it out there, although this isn't, but do just remember if you say no swollen lymph nodes in your charting, you better have checked all of the ones on your whole body, because that's what you just said you meant. So when we're talking about are you on camera right there? Okay.
No, I have to be real mindful on my face.
I guess. I mean, it might be helpful. I don't really want to be on camera, but.
Well, they want you to come closer to it.
So when we're talking about lymph nodes of the head and neck, so we'll just start here. If we're talking about the pre and post auriculars, they go right around our ears. Usually you can feel the pre right around the tragus, and the post they just run up right behind. What do y'all think would make those inflamed or swollen or tender? Ear infections, because they go, the area of the infection, those lymph nodes closest to that area are going to react first. Now granted, if you had some sort of huge infection, could that spread? Absolutely, but we're reel it in, come on back to the ranch. We also talked about our post-occipital lymph nodes are right at the bottom of where the skull meets the neck. And so sometimes we'll see those inflamed with scalp infections because that tends to drain kind of back. You also have submandibular lymph nodes that run right under your jawbone. And really to palpate those, you usually kind of you can't have them looking way up like this. You need to kind of have it down so that little under neck fat isn't all stretched out. But those, what do you think we would have those inflamed with? Well, okay, so we're talking about right under the jaw. Yeah, so teeth, tooth abscesses, canker sores, cold sores potentially, those sorts of infections in the mouth tend to get those submandibular lymph nodes inflamed and tender. And then we have our cervical chain. So you actually have a superficial and a deep cervical chain that runs down your neck. And that's where you're going with the pharyngitis, strep throat, things like that. That's when we typically see those further down in the neck. So those were the like 4 specific areas that we covered more specifically, because in the pediatric age groups that we've looked at, tooth infections, ear infections, throat infections, those are all really, really super common things. So what would we expect to feel, and what might the client report if they had issues that we can assess with the lymph nodes as well? Yeah, so tenderness, so they'll feel that. They'll be like, it's a little sore on one side maybe, or when you're assessing, they might react or kind of pull away or say ow or something like that, because they can be tender to touch. What else? Inflammation, yes. They'll be obviously more swollen and easier to palpate than typical. Most people, you can't really palpate your lymph nodes the majority of the time. Also, they might even be a little bit warm to touch. Sometimes that can be hard, especially if they're already running a fever, like with an ear infection or something. Then it's like, well, are they febrile, warm, or is it warm in that area? So that can be kind of difficult to tease out. What would be abnormal lymph node findings that are like really, really concerning? We expect lymph nodes to be inflamed in an area where there is an infection. That they go hand in hand. That's part of your immune system working. But like when we talk about maybe cancer in a lymph node, how would that make it different from just a regular inflamed lymph node?
You can't move it.
So we might feel more in an area inflamed. They are harder. So typically an inflamed lymph node that's reacting to an infection is kind of firm, but still has a spongy texture, almost like a pea or something, or maybe like kind of rubbery feeling. But when we feel with cancer, a lot of times they're like really hard, like gravel, like real hard. And then even when they're inflamed with an infection, they're still mobile, they're movable, so they'll move around just a little bit. But typically, if we see a cancer, then they're like locked in place and you really can't move them at all. So there are kind of degrees of abnormality. But what I really wanted y'all to focus on was those 4 specific areas that we talked about, and just more of the infection and what you might assess with that. So if we see their throat looking really red and sore, then I also want to feel down the cervical chain and see if we have associated lymph node inflammation and tenderness to go with that, because I would expect that. If I see their red ear is really nasty, I'm going to feel the pre and post auricular areas and see if their lymph nodes are inflamed and reacting to that. Good question, Jordan. Did that get you? Oh, look at y'all all answering on here. Very good. Okay. Good questions. What else? I'm just hanging out.
What would you say is the most challenging subject that will be on the final that students have the most problems with?
That's just memorization.
And I don't
I don't know that there's one section over another that's really challenging. I think every student has different strengths and weaknesses, that they find some subjects or disease processes more interesting or more, easily digestible than others, but I don't think across the board there's gonna be one that we're just like, oh, it's this one.
Well, what's the most missed?
The most missed, it's just very, variable.
Guess we can go based
Good
off
answer.
of which test had the lowest score average.
Well, but you do know that there are people who made A's on all of our tests.
They're not.
Those are outliers.
There are. They don't count.
Well, I think in general, if you just wanna go in general, I think infant growth and development is typically difficult because there's so many milestones to cover. I think cardiac is typically difficult for y'all because the heart blows people's minds. And then I think
Y'all
respiratory
hated respiratory.
is typically difficult for y'all. But that's just kind of real general. Also, I mean, we're still going off of just this remediated content, so some of y'all might be looking at that like, I know all of those things. Great. That'd be good.
Okay, we have another question in the chat.
Oh, that's Candace.
Can we go over manifestations and nursing management for a child with congenital adrenal hyperplasia.
And are we gonna keep on this track of just doing the questions, or will we do the?
We can say we should,
That's okay.
I mean, I think
Well,
we
because
need
we'll
to
get
make
to
sure
that.
we're
That's what I'm
asked.
saying.
Okay, oh, okay.
Yeah.
You do, you do. I mean, if it was in a content remediation topic, then is it on the test?
No.
You tell me.
I mean, y'all can.
Like,
yes.
Will there be?
Thank you.
Let's go back over what I said from the very beginning.
No, it won't be.
If content does not appear on content remediation, the odds that you will see it on the final exam are in the negative numbers.
Okay, but it says, like, management for dehydration, and then you have maintenance fluid rate, so then we would have to calculate the maintenance fluid rate, because it's part of dehydration.
Did it say that?
They're not gonna be like this super in-depth per topic, it'll be like more the bigger picture.
Wow.
Um,
So many points. to
so,
test you
yeah.
on these.
we, again,
Right.
we are not adults. We've been, Mhm. I mean, these are very kind of specific.
Yes, they are.
If it was on your remediation topic, I would be able to speak to it thoroughly. And think of ways that you would apply that information as a nurse, which y'all are all really about to be in very, very short order. Oh, and it won't be like, you know, call the nurse, cause now you're the nurse. So, I mean, like, for example, you know, placement management of enteral feeding tubes, which is right here on intro. I mean, that's specific. Where do they go? What are they called? What do you do with them? How do you get them in? Those are specific things. Okay, what do you want us to be doing?
Like, go through our things. Tell me what you know about this.
Okay. Can I start since I'm intro? We just going by exam? Okay, bless you. So, the very first thing is the normal or expected vital signs per age group. I'm not going to have y'all name those off, but you all have the sheet. That is just memory. Now, if I'm gonna give you something that I want you to notice is abnormal, am I gonna be like one out of range?
No.
And neither is NCLEX, and neither is ATI. Because what's an adult blood pressure supposed to be? Right. If I'm 122 over 80, are you worried? No, I'm not. I'm dying. So just remember, like, the goal is not that you just absolutely have a memorization of something, but that you can look at that and be like, you know what, that's still fine, or I am concerned and need to follow up on this. That is our goal. Think about it like that, but I do know that you're gonna have to see some things on the questions. We did the lymph nodes already, so we're good there. Okay, teaching and communication techniques based on age and developmental level. So let's just start, although with infants, there's not a lot of teaching we can do, but communication is not just verbal, it's also nonverbal. So how do you like build trust with an infant client? Yeah, holding, gentle touch. What now? Doing things on a schedule, consistently, talking quietly and softly, still having them close to their caregiver. What if it's like the temperature it is now in your exam room or hospital room? You just chopping that kid naked and rolling them all around? What do you do? Keep them swaddled, only uncover one part at a time, right? And that helps to keep them more quiet. Do you want to assess them when they're like starving? Why? All the vital signs are gonna be high. Can you hear anything besides them screaming if they're yelling at you when you're listening for their respiratory sounds or heart sounds or bowel sounds? No. So when's the optimal time to feed? And then assess. Like, what's our gap there? Yeah, you can do it like 2 hours after, or that would usually be also fall 1 hour before, most end up feed every 3 hours. So that they're not so full that you roll them over and they puke on you, but they're also not starving and screaming at you. Okay, so what about toddlers? What do we know about toddlers? Oh, gosh.
Follow a routine. Let them make a decision.
Yeah, so they do like the routine.
What is their main task? Why though? Because what is their main task they're trying to accomplish, they're trying to achieve? Autonomy, yeah,
Yes.
they wanna do it themselves, right?
So they do like to say
So
no.
they do like to say no because of that, because they wanna do it themselves.
But when you're communicating with them, then do you give them yes, no options?
No.
Do you wanna shower now or shower later?
Right, it's not do you wanna
Two
shower,
options that are appropriate.
two appropriate options, because if you give them a yes, no, a
They
toddler
also might not
is just gonna say no.
understand it now and later.
Yeah.
Like,
Like blue cup, pink cup.
yeah.
Sure. Blue cup, pink cup, do you want juice or milk, those sorts of things.
We're
What-
gonna shower, but.
Two appropriate options.
So with the time thing, cause I know that was one of the questions where you all had asked about the child parent had left and you, one of the responses were, your parent's gonna return in the afternoon or something. What was that about that you said about afternoon and time and things?
That was actually a preschool question, and that's not actually on this, but I will answer you. So,
Mhm.
remember in preschoolers, they don't have a good concept of clock time, so you need to couch it in terms, you can't say like your parents will be back at 6 or at 3, because they're gonna be like, okay, now is it 6? And you're like, well, no, they can't read a clock. So you need to give it to them in terms of something they can understand, like, they'll be back when you wake up from your nap. Or, you know, like something that they can relate to in their day, because let me tell you, they're sleep, food, and television show oriented. So you tell a preschooler, like, after Bluey, then you do whatever, and they're like, got it, I know what's happening. Does that help?
Mhm.
Okay. So yes, for toddlers, only, give appropriate choices, don't give yes, no answers if you expect a yes, because they will just tell you no, and then you're stuck. And also, to go in low and slow, because they still have some of that stranger danger going on, especially early toddlerhood, so don't go in thinking you're gonna be the nurse to assess them, take them from mom or dad or caregiver, because you are going to upset the balance of power in that child's world, and it's not gonna be pretty. Preschoolers, we still have some of that, still have to go in low and slow and let them warm up, but remember, preschoolers really like to please, so if you can give them like little, tasks and then praise them on that, they love the praise. What about school age? What do we expect on that, kind of communication wise?
They wanna know what's going on.
Yeah, so school age students. Yes, most school agers are students. Those kids really do like to know what's going on. They like to be involved. They like to ask questions. So you have to kind of gauge your teaching based off what they know, but expect that they're not going to be good with you just doing all the things and not telling them about it. They want to, like, what is that? Well, what does it do? Why do you use that? And they really expect, like, toddlers and preschoolers sometimes will start asking lots of questions. They just keep going and breezing through and sometimes frequently don't care about the response. But school age kids want a response. And what about adolescents for communication?
Be honest.
Yeah, be honest, not judgmental. You want a nice open line of communication where they feel like they can tell you something and just be open. Also, if you give them yes, no questions, they will typically give you yes, no answers. So ask questions in a way that ask them, open-ended questions that ask them to elaborate more, because a lot of teenagers, y'all, we're all, some of you very still real close to those teenagers. You ask them something like, how was school today? And they'll be like, fine. What was your favorite thing that happened in school today? Yeah. Well, nothing, I hated all of it. Yeah, or I don't know. So some of those.
You're nice and privacy.
Yes, you're not, that's very good. Privacy, especially even in our late school age, we need to give the opportunity for some privacy and check in about that. And late school age and into adolescence, we also need to be trying to pull aside with some time away from parents, so that if those kids had some questions that they maybe didn't want to ask in front of parents about, like body development, sexual development, experimenting with drugs or alcohol, those sorts of things. Again, sometimes that's hard to provide, but we try to offer that space where they can ask questions without a parent there if needed. Okay, sorry, I'm freezing. It's on my closet door.
Yes, ma'am, thank you.
Oh, yes. All the way around. Okay, enteral tubes. What is an NGT? What does that stand for? Nasogastric tube. So that is inserted where? And it sits where? Yes, it's inserted right or left there. The end sits in the stomach. OGT. Orogastric, so inserted through the mouth and sits in the stomach. What about a TPT? Transpyloric. So the end sits right past the small intestine, the pyloric sphincter, so that leads into the small intestine. And where can we put them in? Eyes, ears? They can go into the nose or the mouth, yes. And then what about a GT? Gastrostomy, so it's surgically inserted through the abdominal wall. So we have that little phalange that pops open and goes straight into the stomach. Management, so NGs and OGs, what can we put in there? Feeds, oral medications. If it's a crushed oral medication that was a tablet, what do we have to be careful about? Yeah, it can't be enteric coated. It can't be extended release where you open it and all the pretty little balls fall out. Can't do that. And then we have to make sure that it's crushed well and mixed with some sort of liquid because it will also potentially plug up your tube. Same for TPTs. We can do feeds and meds through there. What's our consideration between a feed through the NG or OG and a feed through the TPT? The volume and rate of time. Because our stomach, where the NG and OG sits, it can expand. Y'all just had Thanksgiving dinner of some sort, I'm sure, so y'all know about that expanding stomach. But our small intestine can't do that. So when we are feeding into the small intestine, we have to do low and slow rates. We can't just do a bolus feed like we can do into the actual stomach. And then GT, we're not doing all the different variations of the GTs, because those of you who are really diving into peds, you know there's a lot of different kinds, but just the regular GT would feed directly into the stomach, so we can use that. Let's see. Yes, probably good on there. And then placing and managing IV therapy. So what about placement concerns for pediatric population? Might have to have some help. Definitely could use a second set of hands a lot of times when you're going in to place the IV. A lot of times we can use a transilluminator and try to get it in one stick. That'd be great. You want to have all your supplies with you so you're not in and out of the room. That's just atraumatic care, right? Also remember, adults, what napkin? Yeah, wrap it up. Adults tend to guard their IVs pretty well if they're in their normal headspace, but kids will full on get that wrapped up in their blanket and yank it out and not even think about it. So make sure that we tape it well. We use items like a house or something to cover it so it's not getting hung. And then especially for those little vessels, how often are we checking? Often. So your institution will have a specific time that you have to check, but as the smaller the person and the smaller the vessel, the more likely it's gonna go out. And especially if you're running something that's, hard on the vessels or is running at a high rate, you need to check it more frequently. I think we're probably good on that as well. Good job, guys. All right, I'm not on one.
So anyway, whenever you get a chance, sorry, did you go over the cardiac stuff that you had situated?
Yep, we're just going by.
We're going
by
out
exam.
exam,
Yes.
so we'll get there.
So we're doing exam 1, concept remediation now. That was all the intro exam that I had.
Okay, so our infant grant, oh, hold on. I hate that microphone. I'll be screwed, they'll hear me out down there in 1500. Okay,
They
so,
probably do anyway.
I'm sure. Psychosocial development of the infant, what is our stage? Trust versus distrust. What is our goal? Trust. How do we get there?
Doing what we said we did.
Doing things when they cry, change,
So it is providing of their basic needs, right? But what is important for the baby to do first? Yes, they've got to signal that they have a need, right? We don't just willy-nilly go and start doing everything. Because they learn to get a little frustrated, they cry, and then we respond to that, and that over time will develop trust, right? But then essentially, we're just meeting all of the needs. Feeding, changing, all of the things that you all just named. So, it's just important for them to know they need something, to be able to tell us they need something, and then for the caregiver to respond to that. And I mean, literally, that is in a nutshell. So if we fail to do those things, what happens? We land on more mistrust. What does that look like? No, their needs aren't met. What does that do for the baby? They tend to just put frustration on frustration, right? So then now they're crying, they need something, nobody is responding to them. So they definitely fall more on that mistrust side, and then they start to set themselves up to feel like people are not going to care for them. And so if we fail at stage 1, what happens then when they go to toddlerhood like that? We're just kind of fall off from there. Let's see, are you watching? I'm trying to remember what's over there that's kind of in my screen. Okay, so what did we say about toys? Nothing was small part. So the toilet paper roll is a pretty good standard rule to go by for choking hazard. What are other things that, I'm gonna call them, that we talked about the infant toys in regards to age? That if it is a toy intended for a 4-month-old, can an 8-month-old play with it?
Yes.
Sure. We can pull from the bottom, but we don't take from the top. So, and the thing is, I mean, it's really probably not gonna be like a choking hazard. If it's a choking hazard for a 12-month-old, it's probably a choking hazard for all of them. But the thing is, like, you remember we used a lot of the pictures, the busy box with all the latches and beads and knobs. What is a 2-month-old gonna do with that? I mean, maybe. They're not gonna be able to do anything with that, so it's not gonna be helpful for them to play with it. Obviously the walking toys should be pretty self-explanatory. Don't give that to someone else. Okay, what are things we cover, what do we care about infant nutrition? What are some of the rules we talked about? Breast milk when they're small. When do we introduce solids? What do we introduce first? Before all else. What's the first? Rice cereal. Yeah, so that's kind of the first thing they get. But then once we do start introducing, it is vegetable first, right? What's the threshold to introduce new things? 3 to 5 days apart. Okay, I think that's probably the high points for nutrition. Now, infant reflexes. Online, y'all just missed the best representation.
Chloe asked what age to get introduced solids. Sorry, to go back to the before you.
Oh, to go back, 6 months, sorry, Chloe. I didn't see that.
That's like actual solids, right? Not like.
Well, they
Rice.
consider it. Well, rice cereal would be, it is classified. We introduce like a rice cereal first. That's the, I'm gonna teach you the textbook ways of the world. This is
That was
where,
recommended by the American
that,
Academy
yes.
of Pediatrics.
That is. But remember I told you, mamas will be like, oh, they won't sleep all night and they're 2 weeks old, go ahead and fill that bottle full. Tell mama she's wrong.
Shake it up with it.
Yeah, we have to go with what's tried and true. The actual rule is to be 6 months of age.
And remember, y'all about to be real nurses, and you're supposed to do real teaching, not like, you know. Yeah, not meemaw teaching. We all have those aunties and meemaws, you know, like, but you're supposed to do that. Oh, it's fine. You turned out fine.
Whatever you used to study for reflexes the first time, probably a flashcard-ish, right? I mean, that's gonna be helpful here, because unfortunately, those are just kind of rote memorization. There's no way around them. What is the other thing we have to consider when we're looking at things like that, though? About their age? What if they were premature? Don't give up on it, right? You have to adjust for them being early.
So do you do that's the math. I did not say there would be zero numbers on this exam, I said there would be no dosage calculations. There is.
Yeah, I mean, like,
So what's
some-
the formula, go ahead and drop that.
How to calculate the premature versus where they should be.
Oh, you're gonna let me be a real teacher, and I don't know how to work it.
That's one of the facts. It's one back.
Oh, yeah, they have their own.
I mean, it's very,
3 weeks, right? So that's where we're starting. You can type that out. So, yes, this is full term, all the weeks in a pregnancy. So, if you had a baby born 12 weeks early, what weeks were they born? Okay, that's easy math, kids. So if your baby was born at 28 weeks, that'd be their gestational age. That means 12 weeks too soon. Are we in agreement here?
Yes.
Okay. How many months?
3.
Okay. Could you
Divide by
just
4.
divide that by 4 equals. What did you just say?
So if you have a 6-month-old, you take the 3 months off,
And evaluate them as what?
and they're a 3-month-old actually.
Does everybody see that? Is it okay? So it's basically just knowing that 40 weeks is a full-term pregnancy. What you take that, whatever their gestational age is, and subtract it. And then we have to know how many months that is. 4 weeks in a month. And then you just take however many months they were early off of their actual age to get to the age that we're gonna evaluate them. Now, and it really matters when they're real early. And especially think about like a 24-week baby, that's substantially early, right? So you can't go around just hoping that they're caught up by the time they're 2 months old, they're not going to be.
Does that change their vital signs at all?
We're not gonna get that sideways. We are not gonna get that sideways. Yes, sir?
So for the example on the board, we will evaluate them as a 4-month-old,
As a 3-month-old.
3-month-old?
Like if we, oh, well, I didn't give you 6 months, that's where I went wrong. That's not easy, man. I wanted this, well, we can still leave it there. How many months is it, 28 weeks is how many months?
What'd you say? It's 7. If you're doing it by 4 weeks, it's 7.
Right, so really, this kiddo in particular should be a what? 4-month-old. Sorry, I was thinking 6 months, because that's what I said in my brain. Brian, is that why you were sideways? Does it make sense now?
Yeah.
Sorry, that was on me.
no,
7 months minus 3 months.
they were born at 28 weeks, so they're 3 months early, right? So at 6 months, they would still be.
Well, but what I wrote and what I said was.
Oh, okay.
Yeah.
That's what, I was doing that to myself.
I think you guys,
I mean, I think y'all subtract. It's just subtracting however many weeks they were early and just getting rid of that.
right.
So you would evaluate them here.
Okay, how do you know, tell me some of the differences between being mildly dehydrated, because we already said that moderate kind of is not super substantial, right? So basically, if you look at mild dehydration and severe dehydration. What are some key differences between the two?
No tears.
Definitely in a Fontenelle.
No tears.
In which one?
And severe.
Severe. If you're severely dehydrated, you're crying and you're not making tears, that's very bad. What else? Sunken Fontenelle. Pretty telltale. Because if I told you that a kid had kind of had diarrhea for, 6 hours out of the day, but they were pretty alert, their Fontenelle is flat, capillary refill is less than 2, how do you feel about that kid? Kind of mildly dehydrated. What would you want to do about that? Did you say water? I was like, do not ever give the babies water. They don't get water.
You didn't indicate how old the kid was. And Kayla's
Right.
If their Fontenelle is still open, that's the We'll go back right there.
Well, but the anterior fontanelle.
Is it their posture?
When is anterior fontanelle?
Quit putting them in the weeds.
A 1-year-old could definitely have water.
If you had a 4-month-old baby,
Thank you, appreciate it.
I thought I just ended their whole of the week. That was gonna be Okay, so if that baby was 4 months old, what is the treatment for like a mild dehydration?
Pedialyte.
Which is basically just electrolytes, right? We're gonna oral rehydration solution. So, if you had a kid that was, no, I won't even say a kid, I like babies. If you had a 6-month-old that had some sort of stomach bug that it was kind of hard to arouse them, their Fontenelle was sunken in, their cap refill is 4 seconds, and now they're kind of cool and mottled, their extremities, how do we feel about that? Very different picture, right? So that is significant dehydration, so what do we do for that?
You give 20 mils per kilogram of IV fluid dose,
Why do I want to do that first?
because that's what the what it is.
But why do I want to do that first?
According to the American Pediatrics.
Yeah.
Where's my
They're learning something.
Why do I want to give a fluid bolus of 20 mils per kilo to a kid severely dehydrated?
Circulation.
Why don't I just give them some IV fluids? Let's get going at maintenance rate.
You have to get it back up there. You have to deficit, and then you have to get
You have got to fix the deficit first. If they are that dehydrated, they've got an empty tank. We have to fill it up and then move on from there, okay? Not dosage calculation. You do not hear dosage calculation come down on.
What did you say were the mild dehydration signs?
I mean, any kid that, if a kid is coming to us that has otherwise been, running a high fever, throwing up, had diarrhea, we expect them to have lost a little bit of their fluid, right? But if they're still alert, with a good capillary refill, I mean, those kind of things we're a lot less concerned about. So it's really looking at a sunken fontanelle, tinting of the skin, normal dehydration signs that y'all know. All on the severe side. That's why I didn't want y'all to really focus on moderate, because there's so little that differentiates between standalone, oh, you're moderately dehydrated.
So would you say mild dehydration is more like the subjective symptoms of it, like saying, oh, he's been throwing up, but otherwise presents as a normal kid?
I mean, pretty loosely, yeah. I mean, if they had something going on that I would have expected them to be losing a large quantity of fluid, then most kids don't drink enough as is, let alone a kid with a problem. But it's really teasing out, if they are starting to have circulatory compromise because of their fluid balance, that's very bad, and we need to do something about that relatively quickly. Okay, you feel okay there?
I have a question. Okay, so we just went over mild versus severe. How are we differentiating between moderate and severe?
We're not.
Well, we're really not. That's too, there's like such little impact to put them in that category, that it's like if you can know when somebody is just
mildly dehydrated versus when they're severely dehydrated, that just doesn't wash out on them. Okay. Anybody remember about thrush?
You can realize that. Or the ones in the front, probably includes the treatment.
So what is the problem? What is it?
Yeast infection in the mouth.
Sugar.
Fungal?
Well, like,
How, what we know, how, what?
How do you know it's
What does it look like?
It doesn't come off.
It doesn't come off. Because a baby that's drinking formula, they can have white on their tongue, right? But when it doesn't come off, that's pretty telltale. So if they've got these white patches in their mouth, a lot of times they will have an associated diaper rash to go along with it. What do we want to do about it? Or what? What's it? Fluconazole? How do we administer fluconazole? Okay, how do we administer nystatin?
you coat them, you coat it.
How do you administer
It's just an oral med that can, so fluconazole that's given once a day, we can give it with food, right? Normal oral med. We give nystatin several times in a day. And you've all decided that it's after the feeding, yes? Yes. Because how do you actually give it? Right, so that's when, remember, we had like that pink swab, put the medicine in like a med cup, soak it up on a swab and just coat the whole inside of their mouth. If you give that and then feed them, what happens? Gone. That's what I say, you're probably drinking that. Hold on, let me see, for,
It's not a moderate management, we aren't giving, oh, no, that's correct.
Okay, so we had a kid with an ostomy. What is some teaching that we would do with that? Okay. So what about their clothes? Loose fitting. What do we do about cutting a hole for the bag? How should that be? Should be close to the stoma, not restrictive, but close, because that stool's really acidic, right? So it would really excoriate that skin. When do we empty the bag? Okay. When do they need to notify the provider? What makes you concerned? Right, if it were dry or if it were like a really dark, purpley, blackish color, that's bowel death, right? If it were bleeding crazy, yeah, that would be blood calling. Okay, what can you tell me?
Cutting a hole for the bag.
Well, like when they're cutting a hole for the stoma side to fit through the bag, you don't want there to be a big gap between, you don't want a giant hole for a little stoma. Like you don't want it so close that it's gonna restrict the blood flow, but you want it to be as close as you can get it where it's still well perfused. Because the output out of the stoma is really acidic, so it will just eat that skin up. Trust me. We'll do that.
You know, we're an hour in, and we're partway through one.
Because you took 5 hours.
Yes, sir.
Talking about cleaning it again, so it's just like mild soap and water.
Okay, intussusception. What is it?
Telescope in the mouth and another one.
Okay, how do we know it's happening?
Wait, what?
They have the jelly.
And
Yes.
Where are you palpating a mass?
I am a quadrant.
What does it feel like?
Sausage.
Okay.
It feels like sausage. It just
Okay.
on their stomach. It feels like the chili.
Infection immunology.
With the sauce.
What do you know about? What antipyretics are we gonna choose for our pediatric population? Acetaminophen or ibuprofen. How old do they need to be for acetaminophen?
6 months.
Yeah, any age can do acetaminophen, but ibuprofen, there you go, they need to be at least 6 months old. And then what are we not gonna give? For fever management, right? That could be-
Oh, hold on, Clark, will you unmute?
Oh, sorry. There we go. Got me now. All we talked about so far was acetaminophen and ibuprofen, and no aspirin for our peds population. For fever management, yes. Let me finish that sentence. Okay, and I'm just gonna fire some questions. If you were initiating droplet precautions, what would you put on to protect yourself? Gowns, gloves, and a surgical mask. What about airborne precautions? What else? A gown, glove, mask, N95 mask. What else?
Maybe a face shield.
Maybe a face shield, yeah. And they need to be in the negative pressure room. What are some of the disease processes that you would do airborne that we talked about? Measles, tuberculosis, we didn't talk about tuberculosis specifically, but yes. Varicella, MTV, right. And then what about droplets? What were some of the ones we talked about for droplets? Rubella, scarlet fever, meningitis.
Are you gonna have on there like rubiola and rubella and have to, because that always.
So don't get into weeds, but I would know what kind of symptoms you might see and what precautions you need to take.
For both?
I mean,
According to these,
for the general ones
Well,
that we talked about,
are you gonna use rubiola or like?
I'm gonna use the the proper term for it. Yeah. I know we give you a lot, we always say, well, this is also, varicella is chicken pox, but you're not gonna see chicken pox on the NCLEX, you're gonna see varicella. You need to know it by its proper name.
A rubiola is measles, right?
Yes.
But rubella is rubella.
Rubella is like German measles, so rubella, yes, you can just remember rubella, and then rubiola is.
Rubiola is, there's a random E in the middle of rubiola, and then there's a random E at the end of airborne. So I put the E and the E together, because in airborne should be spelled just ends with an N, but it ends with an E. And then rubiola has an E in it.
Rubella, but it's.
So
not-
rubiola.
It's like rubiola.
When the two E's go together.
Her memory. Okay. Food and latex allergy management, just review that, list of foods, general, in general, what foods do kids with a latex allergy need to avoid? Like in general, lots of different fruits, right? Kiwi, bananas, like, just in general, it's lots of fruits. There's like one random chestnuts in there. I mean, I don't really eat chestnuts very often, but they can be in stuff, especially at the holidays. And then like, what are some of the things that they're gonna do to diagnose a food allergy? Like if you're trying to figure out if you have a food allergy. Allergy testing. Skin testing is maybe more for like environmental things, but What'd you say?
So there was the RAS, remember those different tests? The radio allergosorbent test, RAS, different blood tests, right? Or you can just, what else? Give it to them and see what happens, or take it away and see what happens, yeah. Yeah. And then having their an allergy and anaphylaxis plan in place, so they know what to do if they were to start having an anaphylactic reaction to something. Okay, assessment interventions for acute otitis media and otitis media with effusion. So just in general, what's the difference between the two? What's acute otitis media? So, it's like infectious, right? There's fluid behind the tympanic membrane with otitis media with effusion, that's just fluid is behind there. So that can affect their hearing and make their ear hurt, but if it becomes infected, that's acute otitis media, then we need to do antibiotics and treat that, right?
You always do antibiotics?
So that sometimes they'll wait, if it's just one ear, if it's both ears, sometimes they go ahead and do it, sometimes if it's just in one ear and it's mild, they might give them a day or two to see if it gets worse.
Sometimes they do viral.
Yes, sometimes they'll wait to give them a couple days and see how it progresses before they start antibiotics. Jordan says, do we need to know both foods for latex, known latex, and cross-reactivity? Both foods? I might need you to clarify that, Jordan. I have two lists. For the latex, I think it was just that's just a general list of the foods for latex. Is that what you're talking about on the slide where it talks about latex allergy, Jordan? Yeah, that's all one list, it's just two columns. But those are, okay, yeah, those are all foods that can have, like the proteins from natural rubber latex can be, like those foods can have those kind of proteins in them, so then that, it could have an allergic reaction to those too. Any other questions that y'all have about infection, anything else? Okay, what's next? Named toddler. Okay, we already talked about what their primary task is. And that kind of goes along with the psychosocial development. They're trying to be autonomous, so then they say no all the time, they throw temper tantrums, because they want to do everything themselves. So what was a big thing we focus on because of that? Safety, good. Keeping them safe, watching for choking hazards, stuff with small parts on it. If it can fit through a toilet paper roll, they can choke on it, so make sure they're being supervised. Cognitive development. We talked about, give me an example of tertiary circular reaction. Remember that? So when they, yes, so they'll do something to get a reaction, right? But that's more advanced than like an infant sucking their thumb and it feels good, so they keep doing it. Then the shake a rattle, that's like secondary circular reaction. They shake a rattle, they like the way it sounds, they keep doing it. But as a toddler, now they've thrown something in the floor and they see a bigger reaction, so they see what else they can do. And it just goes, their thinking is just becoming more complex that way. What's an example of domestic mimicry? Playing in the house, vacuuming, they wanna do the chores around the house, just like mom and dad or whoever they're watching around the house. Good. All right, physical growth. How many pounds should a toddler gain each year of toddlerhood? 3 to 6 pounds. About how many inches they grow in height? 3. About 3 inches a year is kind of expected. And then what other things that I talk about there, like with their head circumference and their chest circumference, those.
It's the same.
When
That belly and the bow.
they get a little pot belly, they kinda get bow legs, those are normal. So when they're about 2 years old, their chest circumference and their head circumference should be about equal. Their heads are still kinda big for their body. And that's a normal finding. And then, recognizing a developmental delay, I'm not gonna go through all, there's a slide that literally has the things, like if you don't, we give them a little extra time, we want them to meet their milestones. But it's not like you didn't start walking by the time you were 12 months, so you're delayed, no. We give them at least till about 1.5 years before we're investigating why that's a problem. And then there were some other just kind of classic things on there that you might see a kid doing. Like toddlers, remember they parallel play beside each other, but towards the end of toddlerhood, they should be starting to be interested in what the kid next to them is doing and maybe start interacting more with other kids. And kids who might be delayed in some way, they might not have any interest in that, even by the end of toddlerhood. So things like that, on that one slide about how to recognize developmental delays, so just review those. I had a question back on ear infections. Shania said, how often would they have to have an ear infection before getting tubes? There's not like a hard and fast rule for that, Shania. It's usually if the fluid is persisting behind their ear, not necessarily how many ear infections they've had. Now, if they have fluid that persists, it's gonna be more likely to keep getting infected and they will have multiple ear infections. But it's more about how long the fluid is persisting and if it's causing problems. So there's not like a specific time for that. Does that help? Okay. Questions about toddlers? Cardiac?
Okay, some signs and symptoms of heart failure in a child, what would those be? Yeah, fluid overload signs. So how might fluid overload signs manifest? Yeah, so they might have some edema. What might that do to their urine output? So maybe decrease urine output, so if that says infant wearing diapers. Yeah, so 6 to 8 is a normal amount of wet diapers a day for an infant, so if we're starting to have fewer, remember it's important to kind of have a baseline expectation for these kids as well, because most of our kids who experience heart failure in the pediatric population, a fair few of them were a congenital heart defect child, so they might not be operating on like a normal optimal level anyway. Sometimes then we might also start hearing some of those like adventitious breath sounds as well. If we have some fluid overload, we talked about the edema, the output. That tends to roll over into their ability to, sorry, apparently my watch disconnected to my work email all of a sudden. Either that or everyone emailed me at once. Their ability to do their activity tolerance. So for infants, that's typically eating, because that's what they do that's active. But maybe if they're a little older and toddler or preschooler, what might their activity intolerance look like? Yeah, tiring quickly, not being able to keep up with the things that they were able to do, or if this is brand new and they had no other issues than with their peers. So also, we might see when they are active, if we're in heart failure, we might see significant increases in their work of breathing, right? Things like that. So not just their rate, but also the muscles they're using to breathe and get that done. So what are some general ways that we manage heart failure? Because at that point, if we've crossed over into heart failure for whatever reason, that's not fixable. We're really trying to make the symptoms better, right? So palliate that a little bit. So what are things that we do, like for nursing here and teaching and things?
Repositioning.
Yeah, so we promote rest, and so that would be like clustering our care, making sure we have good periods of uninterrupted rest. If we're going to, we know we have a feed coming up, we don't want to do a big procedure right before the feed and tire them out, or take them to the playroom if they're old enough, and then take them back and expect them to finish all their lunch, that sort of thing. What else did I hear over here? Medication, so what's one of the specific medications we talked about in relation to management? Yes, digoxin. So we have a few very specific things with kids and digoxin, because again, in adults, a lot of times we dose out once a day, and kids, a lot of times we dose it twice a day. So what about missing doses? Do y'all remember that? Yeah. Yes, if you're late and it's less than 4 hours late, go ahead and give the dose and stay on schedule. If it's more than 4 hours late, maybe we were off the floor for procedure or something like that, we'll stick to the schedule and give the next dose. But it has to be documented too. And then, what are other things that we always do with digoxin? Yeah, apical pulse for 1 full minute, and that means you have to know where you expect that heart rate to be per the kid, right? And that age group. What about our lab work? Yeah, obviously DIG level is important because toxicity can be pretty complicated. What are something that that we might see that can complicate the DIG level and predispose us to DIG level? Huh?
Potassium.
The potassium level, yeah. We want to, if we're looking at that potassium level edging up, then we have to be very careful about what our DIG level is doing. Other things about, so also management of heart failure might be oxygen support. Sometimes those kids end up with some oxygen support, especially during activities. They might not be on there all the time. We talked about clustering our care. What about nutrition-wise?
High calorie.
Yeah, so high calorie, high quality feeds, they might need to be smaller in volume but more frequent so they can finish the feed, but we're still getting really good nutrition. What about babies that are bottle feeding? Any things that we might think about for that? So pacing them, but also we don't want them to feed too long. We don't let them go over 30 minutes because, well, actually at like 88 20, but fabulous is 30. Because we don't want them burning more calories than they're going to end up taking in from the feed. So if they can't finish it in that time, then we'll typically finish it through a bottle. Through tube feed. If they can't finish the bottle in the amount of time, we won't keep pushing and pushing. We'll finish it through a tube. Okay. Yeah, that's oh yes. So Shania, that's the failure to gain weight, especially if they're falling off their nutritional goals. And then the rapid weight gain, we typically see that in relation to like the edema and that fluid overload, because that's when fluid weighs a lot. And so if we're not getting it off, then we'll see that. That's a good point. Oh, also yes, in digoxin, if they throw it up, we don't automatically turn around and give another dose. We need to document it and let the provider know, and we'll be keeping track of what that looks like. Because again, we don't want to push them into toxicity. Okay.
Really quick, so for, you said if the potassium is high, like, just test question purposes, like, how would we know, oh, don't give the ditch because that's.
To be really honest, your institution will have a standard. So you'll be like, you'll have a, we hold if potassium level is in this level. Does that make sense? But it's just something that you need to be aware of your lab work. So if you start seeing it trending up, that might be a conversation to point out and discuss with the provider like during rounds. Like, are you all aware? Those sorts of things. Pre and post nursing care. Okay, so a cardiac cath, before we cath someone, what are some things that we need to do before? What now? Okay, consent is important. What is our role as a nurse in consent? Witness. We don't obtain on our own. What else is important? Current height and weight, yes. So, and check allergies, very good, yes. All of those are really important, and especially remember some of the areas that we typically access to do a cardiac cath, and what are those areas? The femoral areas. So We also need to make sure that we are marking our downstream pulse sites from that with a Sharpie or some sort of other not washable marker, so that wherever we have accessed at the end, we can go back and know where those pulse points are supposed to be. Why is that? Yes, so those pulse points immediately after, and for a little while after the cath, and I mean that could be a couple hours, those pulse points are not going to be as strong in the area that we accessed. We just shoved a catheter in there, we mucked around, your body creates inflammation for that, and a thrombus there on the vessel, which it should. We put a pressure dressing on it, which we should, so that means anything downstream from that access point is not going to be as strong. We still need to be able to access where we were finding it before, because that's our baseline, and we want it to return to baseline. I'm not saying it's going to happen 5 minutes after we get finished with the cath. It will take a little bit, but that's why we have it marked. Good job. Oh yes, we do definitely want to check if they are on blood thinners before we go in there and access a large vessel. That would be very good to know. What about post-care? There's actually a little table in your slides and in your book about teaching we would do post-care, because we get to keep them for a while. We keep them flat. We keep an eye on their pressure dressing. That can sometimes be, it just depends on your institution, but usually no longer than 8 hours after. And then a lot of times, as long as they're not going back to the floor, we send them home. So what do the people at home need to know about this?
Signs of infection.
Signs of infection, yes. Signs of bleeding. What would we expect on the dressing? Yeah, just minimal. I mean, we did access the major vessel. There will be a little blood on the pressure dressing we put on, but definitely it should not be saturated. It should not be coming out from under the dressing. We should not see redness or streaking or anything like that. No weird exudate. It shouldn't smell, you know, the things. Also, if there's a younger child that's in a diaper, what do we need to teach if we access the femoral area? Yeah, so we're gonna have to be very careful about keeping that area clean, changing the diaper frequently as soon as you notice it's soiled. We don't keep the pressure dressing on really, we usually remove it by the end of the 12 hours. And then we'll just keep a little, like a gauze and some tape or even a Band-Aid over the area, and change that as needed. So if they're continent, that might just be once a day, like when they're cleaning up. What about like tub baths and showers? Can we soak that area right after we've accessed it? So typically we want to wait at least 3 days before they have like a soaking bath or bath in it. But they can rinse off, like they can scrub down, but don't soak that area. Kawasaki, signs and symptoms.
Strawberry.
Oh yeah, strawberry tongue. What else? High fever that's not responsive, yeah. Yes, their hands and their feet are really red and kind of swollen and puffy first, and then they start healing, yes. What about the conjunctiva of the eyes? What do they look like? Yeah, so they're typically like red and kind of almost would look like pink eye, but there's not any goop in the eyes, no exudate with it. And then we have the strawberry tongue, but also remember like the lips get cracked and sore as well. So what does that typically make our kids act like when they're having all of these things? Well, yeah, I mean, they don't feel well, but extreme fussiness is also a hallmark finding that goes along with that. So you do have to consider that with your nursing care, because that means you're gonna have to spend more time trying to soothe and help take care. And then our expected medical treatment, which is weird. Yeah, aspirin and IVIG. So it's one of the only times we give aspirin to kids as part of a medical treatment. And then our care for the nursing care, besides, obviously our medication administration, is trying to do lots of comfort care. So that would be oral care, kind of lower stimuli room, not for a neuro reason, but just they're already fussy and cranky. So, letting them eat and drink what they are able to with those mouths, the strawberry tongue and the sore lips, especially nothing like acidic, that would be very sore. What about rheumatic fever? Because those are frequently confused by students, Kawasaki and rheumatic fever. So what's our signs and symptoms for rheumatic fever? Yeah, so that sandpaper rough rash, it's not really itchy, but it tends to be diffuse and widespread. Recent strep throat infection that either maybe they had a sore throat, maybe they just never went to the doctor, or maybe they didn't finish all of their antibiotics appropriately. None of y'all ever. What's some other symptoms? Do y'all remember the Jones criteria? Yes. Yeah, so some of the Jones, they have the rash, they might have remember the Sydenham chorea, which is those weird kind of like unintentional movements. They can have a prolonged QRS interval. They can have, yes, good job, Jordan and, oh, Amanda said it, you're pitiful on here. Well, Amanda would know. On Kawasaki. Let's see. Oh, an elevated CSR and sed rate. What do those say? Yeah, those are general markers for inflammation. So those are things that we would see. You might not see, oh, also the polyarthralgia where you're just kind of like achy and, I mean, you would expect that anyhow, not feeling well, but. And then what do we do for the rheumatic fever? Yeah, so we do have to do antibiotics and finish treating that. What's our major concern after rheumatic fever that is? So when it's not just, oh, this was an extra bad strep infection. This can actually affect the valves of the heart and create leaking at the valves. And so how would we know if that was happening? Yeah, we're gonna have to do an echo with diagnosis. And then guess what, we have to keep following up those echo results and make sure, because sometimes they might just have a little leakage and then as they get bigger and older, it gets worse and worse. And these are the kids, again, if you're gonna be in peds cardiac, you can read more about this, but some of these kids will now be on prophylactic antibiotic treatment for the rest of their life. Some will spend 20 or 30 years on antibiotic treatment after this. Treat your strep infections, that's the short answer. And then teaching and support for clients or families experiencing congenital heart defects. So this is general. So generally, I'm just gonna touch on a few things. A lot of those do involve some sort of surgical correction, which y'all do not have to get super into, but no, there are some generals for pre and post-op. We would wanna make sure that family and the child knew what to expect, that they had information in more than one format prior, they have information afterward with what to expect, when to come back, what you need to contact your provider with going home, right? But what are some general things like day-to-day things? Do these kids, if they have a congenital heart defect, they have to be treated super differently? So it does kind of depend on if it's severe, but generally we let the children perform to their appropriate activity level. They tend to pace themselves. Now, we already kind of touched base, and this is very similar with heart failure. Nutrition needs to be good. We need to be really high nutritional values with what we eat. We need to ensure proper rest periods. We might need to be working on oxygenation, and that might mean either clearing out fluid from lungs, like we're on diuretics or something. That might mean we have to actually have some supplemental oxygen, either at home or with activities. That can look different. Let's see. Any questions about? Those are some very specific things. Questions on the cardiac? So far, y'all remembered a lot of things. Okay, endocrine.
Okay. What do we remember about a kid with DI? Right inside. So what do they look like? What are symptoms? All the signs of dehydration, right?
Headache.
They're peeing a whole lot. What would you think, so when you look at like some lab, what does their sodium look like? Somebody said low and somebody said high. I'll tell you one of them.
That's the diet they need.
So they have a high sodium because there's not any water in the intravascular space to dilute it down, right? So we would expect them to present with a high one. Otherwise, it is uncontrolled diuresis. So in someone that is previously potty trained, they're now wetting themselves. That's an abnormal, right? Otherwise, we're really just looking for the same manifestations of dehydration that we already talked about. What is our go-to for treatment? Desmopressin, which is just synthetic vasopressin. How can we administer that? IM, sub-Q, orally, or what? Intranasal. Intranasal, what, there's some like kind of weird rules there, what are they? Blow your nose first, keep it in the refrigerator. What if they sneeze? Give it again. So, now that's imminently, like you give it right now, they sneeze in your face, give it again. If you administer it and they sneeze in 2 hours, I don't care. So it's just that immediate response. Okay, so what do you remember about congenital adrenal hyperplasia? Yes, so there's a problem with cortisol, aldosterone, and our androgens, right? So we either have overproduction where we have sexual maturation, or we have really atypical genitalia. That's the telltale. That is where, remember, to the naked eye, it is really hard to determine whether they are XX or XY. So, do we remember how we treat them? As their age. So we said ask them their age. It's like, well, it could be a baby. Yeah, we have to replace the steroids. So they are on steroids for life. So it's not just right now. Because remember, these, a lot of times when these babies are born, they present in full-blown adrenal crisis, right? So that's kind of our big complication is how we first see them manifest. Where there's problems with their, sodium, potassium, blood sugar, their steroids are all over the place. So we have to replace them with they take hydrocortisone every day forever, okay? Remember the other big thing about the medicine was if they are taking an oral dose, what happens if they get sick, like GI something and they're throwing up? You have to keep an injectable form on hand for times like that where they can't keep anything down. But kind of our really big treatment, so if they present like adrenal crisis, they're super dehydrated, they need replacement steroid, we have to come in with big fluid bolus, just like normal, that's how we treat dehydration, right? And then we'll usually give them a big bolus dose of steroids and then get them on a maintenance dose. But they will be taking those forever, okay? Also, then we tend to do like chromosomes to actually identify if they are XX or XY, and then that is up to the parents if they choose to do anything surgically to fix the outward appearance. Okay, hypoglycemia.
Wait, what was that test called? For the genitalia, the test that you just said?
Oh, like drawing chromosomes. We need to identify based on the chromosomes that they are XX or XY. She was asking about drawing blood. So what are the symptoms of someone that is hypoglycemic? Full anxiety, need some candy, right? So they can be really shaky, they can have some palpitations. What is our treatment? Thank you, Laura. It depends on about their level of consciousness. Remember, we talked, okay, we did talk about this, that if it is someone that is difficult to arouse, I'm not talking about passed out in the floor and unresponsive, that's different. But if you cannot get someone to arouse and hold their head up and talk to you, should you be putting any sort of liquid in their mouth? No. Please don't. So then what do you do for them? What do you do for that patient? You can give them glucagon. If they already have an IV, you can give them a higher concentration of dextrose. But what if it is a known diabetic that's like, I just feel a little jittery and I'm a little sweaty? 15 by 15 by 15, what does that mean? 15 grams of carbs, wait 15 minutes, and give them another 15, right? Okay, congenital hypothyroidism. They are classified. So the manifestations aren't anything really different. We pick it up on a newborn screen, right? Is there anything weird about their little tongue? That's kind of something, kind of, it's enlarged, kind of sticks out. They typically have difficulty feeding due to that, right? Otherwise, they have low tone, they can be a little bit lethargic. How do we treat that? Until when? Forever. So, levothyroxine is our drug of choice, right? So it only comes in a pill form. How do we administer that to infants? Crush and dissolve. You can't do TikTok syringe trick. It works, remember? Well, that was real down and dirty. Respiratory. Okay, so retractions that are below the ribs are called what? Subcostal, below the rib cage, right? So if they are in between the ribs, they are what? Intercostal. If it is right below the sternum, substernal, just as its name suggests. What about if it's up here by the clavicle? Okay, so y'all know now. Let's know again. What is the other thing about retractions? When its respiratory distress is worse, right, you have more of them, and then making sure that we categorize them based on mild, moderate, or severe, right? If you thought you were looking at a kiddo with RSV, what are they looking like? They're sickly, right? They could be, so, I mean, they basically are showing all the signs of increased work of breathing, so would you expect them to have retractions? Yes. Could they be cyanotic? Yes. Yes, all the accessory muscles, they're probably grunting. If they're having a hard time breathing, they do not wanna eat, and that's weird when babies don't wanna eat, right? That should make you concerned. So we said, assessment and treatment. How do we treat them? Are you gonna give them antibiotics? No. Thank you, no, it is virus. So what do we do? So yes, it is a lot of supplemental oxygen, a lot of suctioning, there's gonna be lots of snot involved. So we're gonna clear their airway, making sure that they stay hydrated with IV fluids, monitor pulse ox, things like that, okay? Management of acute asthma exacerbation. Okay, so we wanna check our asthma action plan, but how do we know what to do with the asthma action plan?
Peak flow.
Yes. So remember, in an asthmatic, we can do a peak flow, like assess what their peak flow is, take that to their asthma action plan, and that will tell us how to proceed. If somebody is having a pretty severe attack, what is our drug of choice? Albuterol, because it's bronchodilator. What are the maintenance meds? Yes. Yes. Some sort of anti-allergy med typically. It's just making sure that inhaled steroids are not helping when we are in the midst of an attack. That is daily, okay? So if we're already having symptoms of an acute asthma attack, that is not going to do me any good. Assessment and treatment of pharyngitis, also known as what? Pharyngitis is the same thing as strep, right? But we'll call it pharyngitis, it's fancy name. How are they presenting? What are some symptoms? What are they saying? What are they looking like that are like, oh, they have strep throat? Yeah, anything worried about their palate? They can get petechiae there, they can have a rash, right?
Can you say it again, because sometimes it's hard to hear when people are talking, can you say what the answer was? what you just asked about, what would
So-
you see? You see the sore throat?
Yeah, they'll have a sore throat, swollen tonsils, it's the strawberry tongue, right, cause it's white with the red bleeding through, they can have petechiae on their palate, they can have a sandpaper rash on their trunk. They will have usually a pretty high fever. So what is our treatment here? Definitely antibiotics, and y'all know the rules about giving those by now, I hope.
They can have whatever kind of cool thing that they want.
Thank you, they can have whatever kind of cool thing that they want.
Like a milkshake or.
This is not the same thing as treating somebody that has just had their tonsils taken out. So if your child that you're caring for with strep throat wants a red popsicle or a milkshake, will you give it to them? Sure will, because we're not protecting scabs, right? So these are the kids that can. If it's gonna reduce the inflammation and treat the pain and help them drink things, because we already know that if their throat hurts, they're not gonna be drinking, they will get dehydrated. So if they want a milkshake, charge on. Let's just read through their comments, so then we have just management of a kid with a trach. What is our safety equipment? Okay, so we need a trach the same size the kid is wearing, a trach one size smaller. We need to have a bag and mask, and we need to have suction, yes, it's pretty standard everywhere. So how do we know where we're intervening? If you can noticeably see that the trach tube is dislodged from the throat, what do you wanna do then?
Is it the long-term care?
In any trach patient, you can see it, it's out.
You plug it.
Oh,
Does anyone want to try to just put it back in?
well, I thought that was.
Okay, yeah, so we'll try to get that same size trach back in, but if it does not fit, then what do we do? We go one size smaller, okay, still doesn't work, now what do I wanna do? You are the nurse. So if we can't get the same size, one size smaller, we need to occlude the hole and face bag, okay?
And then you should.
And then hopefully somebody else is already giving you some more help along the way. But if you have a trach patient, what if you have a trach patient that coughs some stuff up and then all of a sudden now their pulse ox is like 85 and then now it's 80, now what do you wanna do? Probably suction them, it's where we try to get you, like, assessing is not always the first go-to. If I can see the trach is out, if I'm looking at it, is assessing their breath sounds gonna be helpful to you at that point? No, it is already out, I can see that. My assessment is I can see that the trach is out. So just know what to do and when to do it, okay? But if a kid with a trach just has some sort of like acute, I'm desatting a little bit, I'm not just gonna rip their trach out. I don't start there, okay? Do you have one? Do you wanna do HEMOC and we'll get
Let's
her?
do HEMOC real quick. She had to take a phone. Okay, we're gonna go ahead and do HEMOC. Luke had a question actually. What was the action we take if the smaller trach does not fit? Plug the hole and face bag.
Yes, so if we try the same size trach, we try one smaller, we plug the hole and face bag.
And then Jordan asked.
No, we do not need to know the cleaning technique for the trach because that's gonna be contingent on wherever you go to work.
Okay, let's move on to HEMOC and we'll come back to preschool when she comes back. Assessments and interventions based on CBC values. Okay, if you are neutropenic, what does that mean? You have a low white blood cell count. What then might be happening or what are you at risk for? Infection. And you cannot fight off infection, right? That's what your white blood cells are doing. So what would you monitor your patient for? What are some signs and symptoms of infection? Fever, chills, Okay, if you are anemic, then what is happening? What count is low? Your red blood cell count is low. So what are your red blood cells responsible for? Carrying oxygen to the tissues, and they also carry products away from the tissues. So if your red blood cell count is low and you're anemic, then what symptoms might you see?
Cold,
Fatigue, weakness, headache, pallor, good. Sensitivity to cold, good. What if it's a baby and they can't tell you that they're tired and have that headache? They might really be on more of the lethargic side. They really might not really care about a whole lot because they're too tired. So what does that affect when you talk about in cardiac?
Feeding.
Like, they're not gonna really wanna eat. They might kind of dip their sacks with their heart rate a little bit here and there. Just be kind of lethargic. Okay. What about if your platelets are low? That's called, say it louder. Thrombocytopenia, good. So then what are you at risk for if your platelets are low? You're at risk for bleeding, and then what signs and symptoms might you see in your patient if their platelets are really low? TBI, tempera, like bleeding in general, yeah, they can get like nosebleed really easy, or just, if they have like an IV or a device or something, they could ooze around that device, like where the insertion is. Or just be really prone to, I think you said bruising, like really prone to easy bruising. Good. And then, so what are some interventions if they're at risk for bleeding? What are some things that you're gonna do or not do? Minimize having to poke them for things. So if there's a reason, like if you're given something IM and they could get it orally, well, you could ask the provider about that. What else did y'all say? No aspirin. Use NSAIDs cautiously. Probably more of that. Do what? Nothing for rectum, like, because that can cause skin tear down there. Do soft, bristle toothbrush with oral care, like be really gentle with oral care. Anything in those mucous membrane areas, you want to be really gentle. That can cause bleeding. Okay. That's kind of that in a nutshell. And then, I'm not gonna go through every single assessment intervention first, but sickle cell anemia. First, what are they kind of at risk for because their red blood cells have that sickle trait? Not blocked. They can be hypoxic, but not always. Occlusive crisis, like the pain crisis, vaso-occlusive crisis, yeah. Because remember, the red blood cells take on that sickle shape and they're like a crescent moon or a sickle. And then all those trying to go through the vessels and they get clumped up. It's not really like a clot per se, it's just that it just can't get through. Now, could they later get a clot in that area? Potentially. But initially, it's just that it blocks the circulation to whatever area that's of the body that's happening. So then you'll see they'll be in extreme pain. And what do we need to do to treat them? Hydrate them, treat their pain. Usually you will treat their pain first because why? What happens when somebody is in pain? What are they doing? They're like tensed up, they're hurting, they're probably breathing faster, they're just, right? If you can treat their pain, what are you gonna do? They're gonna relax, which may in turn help circulation. That being said, dehydration can lead to a sickle there's not enough fluid flowing through the vessels, right? To help things flow, so then you would also hydrate them. Then, if they are hypoxic, give them oxygen. We don't usually just give oxygen, you're gonna treat their pain and hydrate them first, but give them oxygen if they need it, if their fats are low. Okay? What about hemophilia? What are they deficient in for hemophilia A? Factor 8, right, which is one of the clotting factors, so they need that clotting factor replaced. So you're gonna do all the things you just talked about a minute ago with like bleeding precautions. You're gonna be really careful with those kids, and not do things that'll cause bleeding. And then as they grow up, we wanna teach them to be careful and like, they don't really need to play like football and, sports that are could cause them to get hurt really easily. So they recommend what kind of sports and things, activities for those kids. Like swimming, dancing, sure. Yeah. Golf, stuff that's not like contact sports. And then Wilms tumor, what kind of tumor was that? It's on the kidney, right? It's a renal tumor. Don't palpate where? The abdomen, right? So their abdomen might be, distended, because that's where the kidneys on the top, the tumors on their kidney, they have like abdominal distension, and we don't palpate the abdomen because, and you said it, I'm gonna make sure they know too. Why don't you palpate the abdomen if you know that kid has a Wilms tumor? That can cause it to metastasize, and it can spread. And then they can have like issues with their blood pressure, and they can have, what other symptoms might you see because of where the tumor is located? Like nausea and vomiting. They could have some GI issues because it could compress things in their abdomen. What else with the renal aspect of it? Yeah, it might affect their urine output. What'd you say? Decrease urine output. What else?
They're like renal labs be elevated?
Sometimes they're bun and creatinine, actually, I think it says it's usually within normal limits, but it could be affected. They can have hypertension, they can have blood in their urine, they can have, different things because their kidneys are affected, but they go along with that. And then if that kiddo's getting chemo, just in general, remember chemo wipes out the good cells. So they might not be able to make the white blood cells, the red blood cells, and the platelets. So then they're at risk for all the things that y'all just talked about. They're at risk for infection, they're at risk for bleeding, they're at risk for being anemic. So they just are not gonna feel good. And then they also get the GI symptoms, their hair falls out. So we wanna give them developmentally appropriate care in that aspect, so if they're old enough to understand their hair's falling out, then they can wear a hat or, get them a wig or whatever they're comfortable with wearing if they want to. And then just treating the symptoms, the side effects of that. And Jordan, yes, Jordan, you said painful urination. I'm assuming you were talking about with Wilms tumor. I'm not sure that it would be painful urination, although if they were really dehydrated and not peeing enough, then it's more about kidney function. When you talk about Wilms tumor and how it's affecting their kidneys, it's more about like the function of their kidneys. So then it affects their blood pressure and yes, can affect their urine output, but not necessarily painful urination. And then you said all those things about the blood, if you're at risk for bleeding. Good. We talked about those things already. Any questions about HEMOC stuff? Okay, let's do preschool.
So to circle back to preschool, the iron and calcium rich food, that's just a chart in your PowerPoint and in your book that you can just go over. And we've already talked about anticipatory guidance and the primary safety concerns when we were addressing questions. And then how to support preschool growth and development through play. Well, kind of tagging off what Ms. Clark talked about earlier with toddlers, what kinds of play do we see primarily in the preschool age group? Yeah, cooperative play, which means group play, playing with others, imaginative play, dramatic play, they like to dress up, they like to act out. They can do group play with rules and then without rules, so they might play tag, which might have rules, or hide and seek, or they might just be playing house where they embody different roles. So those are all things, what would we not expect to see in play for a preschooler anymore? Yeah, the parallel. Now, they might still, especially if they're an only child or, something like that, they might still do some solo play, that's fine. But if they are only engaged in solo or parallel play and they don't take interest in playing with other kids, that is an issue. So to support preschool growth and development through play, what kinds of things do they want to play with? All the best things, dress up clothes. Didn't y'all dress up when you were kids? And about like play kitchens with little foods and bowls. They might play teacher, have their animals lined up and with a chalkboard or, I used to do that.
I still do that.
Y'all are her animals right now. Play Superman. They can even lots of crafts. They like finger painting. They like tactile texture things like sand tables and water tables. They like the bigger Duplo blocks. They also really like moving their bodies, so things like they can play with a soccer ball, they can kick a ball forward pretty reliably, they run and they jump, they can get on swings, they can go down slides. So those sorts of things are all working, different things that the preschooler is working on. So just making sure you just kind of know what are appropriate to support that growth and development. Obviously, they don't put as many things in their mouth anymore, but we do still want to be, cautious about something that might be dangerous. But we also don't want to give them the small Legos because then they can't manipulate them and put them together and they get frustrated. So it's still kind of like with infants. They have to be on the appropriate level or they could play down, but they can't play up. And like I said, we already talked about the others here when we started.
Okay, so from preschool to school age, do you remember how much their physical growth changes for this group? How much weight do they gain? 4 to 7. How much do they grow? So then what's the other kind of weird thing about boys and girls?
How much do they grow? Sorry, I'm half deaf.
4 to 7 pounds per year and 2.5 inches per year. But remember, boys and girls the same age, if you have a female 11-year-old and a male 11-year-old, who is likely to be bigger? The female, right? And then in adolescent, they'll take back over. Other things, they lose baby teeth, right? Start to be replaced with all permanent teeth. In the later end of the school year, so 11 and 12, they start to develop secondary sex characters. Sorry, it's because I can't see it. So we just covered growth parameters of the school age child, so the 4 to 7 pounds per year, 2.5 inches per year, and that males and females the same age, like an 11-year-old, that the male would be bigger. That in later school age years, the girls will surpass the boys until adolescence. The other thing we said was they will lose all of their baby teeth, replaced with permanent teeth, and that secondary sex characteristics will begin to develop. What did we cover about the nutritional component? We didn't get super ticky, but what is the rules?
If they're more active, they need more.
Who needs more calories? Boys. Particularly boys that are what? Very active, right? If they're playing a lot of sports, then yes, they will need more calories than a girl would, right? And that's really about all that we covered there.
Do you remember how much they're supposed to sleep? So if they're 6 to 8 years old, 12 hours. If they're 9 to 12 years old, 9 to 10 hours. And do they still have night terrors in this group? They will till roughly 6 to 8, and then that should start to go away. What about their cognitive development? What are they in? Concrete operational thought. What does that mean? Yeah, they are. So they start to take things that they know were true and then apply it to new information. Remember we talked about small kids, every four-legged animal is a dog? Suddenly now they know there's a variety and they will name them. Same things with cars, whatever you want to. So they know that things with four legs could be a dog, but they also know that it could be a goat. And this will be my final plug to take one. Still got to go. Other things, now they do start to understand time, so you can tell them in 2 days we're going to do this, and they will know what that means, and they will maybe ask you every 5 seconds. Do you remember the cookies? The thing about, well, like
These be done now.
it could be balls of dough, and then they're stacked and they're spread out on a cookie sheet, and they start to know now that those are all, it's all the same. They can, that if the size, they understand volume, if the size cup changes, that it could still be the actual same amount. It's just the size of the container in, is what has made that change. Leave it in a nutshell. The safety and health promotion, I'll just kind of send you back. Y'all, those same rules have applied from toddler all the way through adolescent. So just, y'all know the general safety rules about household, how they should travel in a car, wearing a helmet, and things like that, okay? Still me. Management of acute glomerulonephritis. And notice I just said management of acute glomerulonephritis. I didn't tell you to tell me what it looks like, right? I told you to tell me what you want to do about it. So what would you like to do about it? They will get antibiotics. What else will they get? So we do give them diuretics. So in the glomeruli, what is wrong? Itis. They're inflamed. So what else might you want to give to treat that? Steroids. Okay. But then, yes, remember this is caused usually by lingering strep infection, so we would want to give them antibiotics to clear that out. And this is the one that is really hypertensive, right? So we'll give an antihypertensive, a diuretic, an antibiotic, and a steroid. So the common medical treatments for yes.
Alright, should we know specifics on those or just steroids?
We'll go class it like just know that you will give a corticosteroid. There's 5 million in the category that you could give. So I wanted you to focus on like the class that you would be giving and not a specific drug. That was a good question. Common medical treatments for GU disorders. And then I went on to say nursing considerations for a child undergoing a VCUG. So it's kind of split, but a 2-for-1. If you are going to care for someone getting a VCUG, what are some things that you need to consider? For a 6-year-old? Pregnancy for who? An adolescent, or someone that could have started their cycle, right? Do we just go in and ask if they're pregnant? No. Please don't, they will lie to you.
They might not know.
They could not know. There's 35-year-olds out there sometimes that don't know. But we will screen them. So then now they're gonna get the test, what becomes our priority? Does it use contrast?
Yes.
It does, so then what do we need to do afterwards? Lots of fluid to flush that contrast out, right?
You need to check for allergies.
I would love for you to do that preemptively before we do it, yes. If you are going to take care of some, y'all remember about hemolytic uremic? Right, all the nasty farm animals in the swimming pools? So we have a toxin, it will lyse, and then what happens? It's a triad of things.
So if you have like viral like gastritis or something, you're taking antibiotics.
Yeah, so it causes the release of these toxins, because antibiotics will lyse into these toxins, and then what happens with the toxins? They start wreaking havoc in the glomeruli, yes? And so they present, we had a triad of things that go wrong here. 3 things. So yes, acute kidney injury. You looked it up already?
No, it's on my site.
Okay. So, acute kidney injury, anemia, and thrombocytopenia. So if you were looking at someone that was possibly anemic and thrombocytopenic, what are they gonna look like? They could be pale. Did you howler?
They could have some TTI.
They could, because remember, that's the hemorrhagic manifestation. So they're, are you concerned that a kid that's brushing their teeth and their gums are bleeding and they've had 3 nosebleeds this week, could they have low platelets?
Yeah.
They could. What do you want to do about it?
Give them back.
Take them to the hospital.
Call the real nurse. Call the real nurse. Call them. It's a plan.
So they are not producing urine, so these are the kids that, and sometimes if they'll go a full 24 hours with no urine production, they will get dialysis. If they are severely anemic and symptomatic of the anemia, what do we do?
Wash, patch, blood.
Wash packed red blood cells. Why are we washing them? To get rid of the potassium.
Is this one be about diuretic or is that the nephrotic?
Nephrotic.
Okay.
And I didn't even have that one on here, and I was sad.
No, that's okay.
I know y'all aren't, but I was. Are these kids gonna be hypertensive?
Yes.
Yes. So what are we gonna be worried about? Seizure disorder. So make sure that you tie those things back in. What sort of education do we provide?
They'll take hand washing.
Definitely the hand washing. Making sure beef is cooked. Wearing swim diapers in a public pool, right? So all of those kind of things, because that's where it started, was with an acute gastroenteritis. Okay, now you have a newborn that got a circumcision.
Well, depends on the type.
Overarching, a kid with a circumcision, what are some things that we're concerned of out of the gate?
An infection.
Possibly an infection. How would you know it was an infection?
Crust and
Oh,
Yellow crust is normal, so what is not good?
It smells bad.
Yeah, yes.
That's what must be.
If it's green or otherwise smells bad, I'm worried about that. Are you worried that they could bleed? Yes.
Some bleeding, like.
Some bleeding is normal, but excessive is not.
It looks like it's being cut off the circulation. That's not good.
I lost my whole train of thought with my phone ring. What else? There's, let me get my sheet.
Keep the diaper loose.
Yes, how frequent, when should we expect them to pee? If not, we would be concerned. So yes, hopefully they'll pee within 6 to 8 hours. Okay. I think that's all I have. Okay.
Musculoskeletal. All right. What are the components of a neurovascular assessment? If you're going to perform one, what are you looking at? So, okay, the 5 Ps, those are symptoms of what? Compartment syndrome. So you're wanting to prevent compartment syndrome by by doing your neurovascular assessment. So what things are you gonna do in a neurovascular assessment? You're gonna check pulses, temperature, what did you say, color, cap refill, sensation, can they feel it, are they having numbness or tingling? What else? Mobility, movement, can you move your fingers, are you able to, or your toes, whatever's distal to the injury, or the cast, or the ACE wrap that y'all put on each other. So then, if you think compartment syndrome is happening, meaning something's too tight or something's restricted, the blood flow is restricted somewhere, then what are you looking for? That's where your 5 P's come in. So you might see pain, you might see pallor, pulselessness, paresthesia, paralysis. They can't, right. So that means that there's some blood flow restricted somewhere, and it's maybe compartmentalizing in an area underneath your cast or your, your ACE wrap or your device that you're taking on. Good. Okay. Duchenne muscular dystrophy. What is what is the general thing that's happening when a child has that disorder? Their muscles are deteriorating, yes. But it's kind of a slow progression over time. And it doesn't get better, it progresses throughout the rest of their life, unfortunately. So, what are some things, when does it kind of usually show itself? How old is the kiddo usually? Usually like preschool, really, like younger, yeah. Like usually around preschool age, and maybe before that too, but they might have trouble, they might have like started walking on the later side, hit some milestones on the later side, but then they achieve those milestones, but they start losing them. They start having muscle weakness and issues with their balance. And what was the thing I showed y'all the video of the kid getting up out of the floor? That's the Gower sign. They use their hands, they walk their little hands up their legs to stand up, and they have trouble getting up out of the floor. Because kids should just be up and running, right? They don't have trouble getting up and down out of the floor typically unless they have a mobility issue. Or unless they're my age. But I'm not. I can get them. And then, what were some of the meds that they usually have to take? They're gonna probably be on steroids. Yeah, they need calcium and vitamin D to supplement their bone growth and bone health. We talked about antidepressants because it's just a lifelong thing, like over time, that can really be detrimental to your mental health. And then they might need cardiac medications because all the muscles all over their body are deteriorating. So eventually that is gonna affect their heart and lungs and how the function of that too. Okay, what about developmental hip dysplasia? What were some signs and symptoms that you see in a baby that's born with hip dysplasia? Uneven hips, but where do you see the unevenness?
The leg.
You see it maybe in the folds on their thighs, the length of their legs, or their knees. When you put their knees together, one will be a little bit higher than the other. What tests are they gonna do to assess if their hip is out of socket? The Ortolani and Barlow test, that's the one where you put the hip in and out of the socket and the baby's just chilling there. Because their ligaments were really loose, because that's how it formed in utero, so it's not really painful right then, because their ligaments are really loose around that area. So what was the treatment if they're less than 6 months of age? Tablet harness, and then once they put the tablet harness on, what should the parents do? Y'all can review that teaching.
Don't touch it.
I'm not gonna go through every single point, but don't adjust the straps. The parents should not be adjusting the straps at home. they come back periodically to get them adjusted, and if the parents think it's too tight, they need to bring them back, but, the provider is the one that adjusts the straps and where it should be. And then what can you teach the parents to do assessment wise? They should be able to keep their legs in it, their lower legs. What should the parents learn to assess? A neurovascular assessment. You can teach parents how to do that. So check their toes and their lower extremities while they're in that. And then if they're 6 months up to 2 years, what's the treatment? For hip dysplasia, the spica cast. So sometimes they'll do the traction first. You remember which traction it is? Bryant's traction, yeah, Bryant traction. Sometimes they'll do that initially depending on the severity of the dislocation. And then they'll do the spica cast. If they're older than that, they might just need to go in and do surgery to get it back in place. And then you go into cast care. If they're in a spica cast, you're keeping that clean and changing their diaper appropriately to keep it clean. Okay. Myelomeningocele is the one that I've focused in on for spina bifida. So just thinking about a baby with a myelomeningocele, what is a myelomeningocele? What's happening? Their spinal column has protruded out. It's usually in the lower back. It can happen higher up, but it's usually on the lower lumbar area. And there's no skin over it, right? It's like the meninges are just hanging out outside the body. So that's a huge infection risk. If it ruptures, what might happen? What will you see? You might see CSF fluid leaking out. What will that look like though? Probably just clear fluid, so it's sometimes really hard to detect. So you have to be assessing that really closely. And then what do we do to protect it until they go to surgery to fix that? Put them on their belly. Put the moistened gauze over the top of it, and you can moisten it with antibiotic solution or normal saline. What'd you say?
So you ain't strap anything out?
Don't strap anything down to it, leave it open so it's not, no pressure on those sacs, basically. Good. And then what assessments, other than watching for CSF linkage, what is another assessment you're gonna do? Check their mobility of their extremities below the defect, because that can affect their nerves, and then it affects their, if they can feel their legs or not. What else? They need a latex precaution. That would be the nurse's job to initiate latex precautions. What else? Think neuro. Because remember, it can affect the fluid. They can have backup of CSF fluid in their brain, so they can get hydrocephalus. So we're monitoring head circumference, we're monitoring their neurostatus for increased intracranial pressure. And that's that in a nutshell, too. Good. Okay, here we go. Adolescent. I'm on a roll. And we have kind of talked about communication already. We talked about, giving them privacy and those basic things. So y'all know there's those slides. Psychosocial and cognitive development is what I've zoned in on here. Kind of the difference of how they progress early, middle to late adolescence for each of those. And physical growth and sexual maturation. So on the slide where we talk about like how many pounds should they gain, or how's their growth affected male versus female. So I'll look between the differences of those. And then on those same slides, there's like a little box that says like order of sexual maturation. So like, what's the first thing that happens for females usually when they hit puberty?
Oh, the period.
You said it. Thelarchy. What is thelarchy? Breast development. Yeah. And then what about for males? What's typically the first sign of like puberty is happening? Testicular enlargement. I'm just gonna brush on by that. Whatever you just say. Good. And then, let me get over here to my slides. Yeah, so we talked about, you know, for females, it's normal for their hips to get bigger, it's normal for males for their shoulders to get bigger, and then their voice gets deeper because their larynx and their pharynx and their lungs, everything's growing there, so that's why the voice deepens, and that's true for females too, it's just not as much, for females. That height and weight gain, that's over all of adolescence, so that's a huge range, 4 to 12 inches for males over the whole of adolescence. 2 to 8 inches for females. They usually start growing before they hit their first period, which is called what? Menarche is the first period. And then usually about 2 to 2.5 years after they have that first period, that's kind of when their growth stops. So remember, girls start hitting their growth spurts before boys, and then boys will hit theirs and catch up. Nutrition recommendations. So we talked about like the calories, and again, boys need more calories than girls in general. And then they need good nutrients all in all, but like what were the ones we focused in on that they need the most of? Make sure they're getting calcium, iron, and zinc, yeah. And so that's all their leafy greens and dairy and meats and good food, whole grains. And then, what's one of the biggest influences on adolescents? Their peers. So that influences everything. That influences what they eat, how they dress, what they wear, well, that's the same thing. What they like to buy, you know, like whatever they're doing, they're influenced by their peers. First and foremost, other than their family, right, their parents. Questions about adolescence? Do you have any questions? Yeah, yes, you're bothering me. I'm distracted. Okay, let's talk about intake real fast. Radiculosis capitis, what is that? Lice. So how do you see lice? How do you differentiate it if they just have dandruff versus if they have lice?
Well, if they're big, they could like
So dandruff will flake off, right, and move. Now, if you see a full adult lice bug crawl, you might see it crawling, right? Get ready to start itching. But if it's just the eggs, they're attached to the hair shaft. Remember, they're not gonna move when you try to brush them off. They're gonna be attached to the hair shaft. So what is the treatment for that? The permethrin shampoo, what concentration?
1%.
The 1%, yeah. And then, what else are you gonna do around the house? Or tell parents to do around the house? All around. Burn education. Vacuum everything, wash everything in super hot water, and if you can't wash it, they can seal it in a plastic bag for up to 2 weeks. And then like stuffed animals, I mean, you can wash some of that stuff, but if you feel like you can't actually put it in a washing machine, then seal it in a plastic bag, because then they'll die. The lice will die. So, it's just not prophylactically, you just wanna check everybody to see what is spread. So, I mean, it would probably really hurt somebody to wash everybody's hair with shampoo, but like scabies, that's when you go ahead and just put all the cream on everybody. But the lines, you can check them every day, see if they've got that. Okay. Atopic dermatitis and diaper dermatitis. So atopic dermatitis is also known as
Eczema.
eczema. So remember, they're commonly associated with, these kids have allergies of some kind usually, and they're having reaction, like allergic reactions to things, and they get the skin rash. How does that usually present? What kind of rash, what does it usually look like for them? Super dry, flaky, what? It can have papules, it can be papular, it's really red, but they have really, really dry skin, they're kind of dry, itchy skin. And then, what are the treatments of choice for that? Topical steroids, you can do oatmeal bath to calm the itching, moisturize. They need lots of, like aquaphor, and to keep their skin moist. But using like fragrance-free moisturizers is important too, because a lot of times they have allergies to stuff and they're really sensitive to stuff with a lot of scent in it, like laundry detergents and things like that. Okay, what about diaper dermatitis? So what is happening if they have diaper dermatitis? It's a diaper rash, so it's gonna be in the diaper area, and it's really just like an inflammation. It's not necessarily an allergic reaction like they get with atopic dermatitis, but it's just inflammation wherever that diaper is sitting all the time. So their skin just kind of has a reaction to that. So what did the rash kind of look like for that? Red. What was the other word for red? Erythema, right, erythematous. And that means it's red and inflamed, like you can use that one word to describe a little bit better. What else? It's got lots of moisture, so what was that? Macerated. If the skin is macerated, meaning there's lots of layers of skin have got the moisture. Yes. And it's kind of shiny and flat usually. So we're gonna do, what is the cream that we're gonna put on that? Zinc oxide. Leave them open to air if you can for a little while. Change their diapers frequently, don't leave them sitting in wet or dirty diapers. Teach them about control. No, you do that later maybe. Okay, what are the different skin lesions we talked about? Just know the differences between the ones that I had. So what's the macular lesion? Flat, red, yes. Macular. Get hit by a Mack truck or flat. I love that. I do too. Papular. Raised, like raised, bumpy red. Pustular. And slide. Yeah, it's self-explanatory. Red bumps, they have pus inside them. Vesicular. They're like blisters, yeah, you can got blisters, just fluid-filled vesicles. So then, just go back and review those words I had you like define on your lecture prep. Those, when you're going to document, you want to use really good descriptive words for things, so that you can say this is red and inflamed, but you could also say erythematous and you said it. You could say multiple layers of the skin have moisture, or you can say it's macerated and you covered it. So use your good terminology to describe the skin stuff. Burn education. So that's just the one specific part. There's literally a slide about burn education. Flame retardant clothing, where do you set the hot water heater? 120 or lower, 120 is the highest. Every 6 months, change your smoke detector batteries every 6 months. Keep a fire extinguisher in the household that works. Don't drink hot coffee while you're holding your baby. Test the bath water before you put the baby in. Test the bath water. Turn the pot handles back. Yeah, teach kids when they're old enough that this is hot and it'll hurt you, and they still might want to test that out, and they'll learn real fast. I mean, I think it's kind of in the moment, if you can be like, all right, what do you think? You know, and they might get close to it, but, I mean, obviously, we don't want them to burn themselves, but sometimes they have to learn the hard way. Yeah. Okay.
Okay, let's do your own, maybe not. My ADHD is going strong right now. Non-accidental head trauma or shaken baby syndrome findings. What might we see when we assess this? Yeah, so the retinal hemorrhages are a significant finding. Again, you can't see those just like this. You have to actually use the scope to look at them. We're looking at the back of the eye when you see those. But what are other things that I could just bruising, especially bruising of different shapes, indicating some are older and some are newer. Where would bruising typically be? Yeah, like arms, upper arms, rib cage, where they tend to hold them. What else might we see? Like what if we did skeletal survey, for example?
History of broken bones.
Might see some fractures in different stages of healing, especially in those areas where they're holding them, although to be honest, babies are pretty bendable, so you have to use some force to break a baby. What are some other things, while they're not really assessing with our eyes, but when we're collecting our history and our data gathering? Yeah, so if the stories between caregivers are inconsistent, or on the other hand, is just logistically, you're like, how on earth would that even happen? Like, it sounds so far-fetched. I'm not saying far-fetched things don't happen, but, those are things that we have to investigate further. Yeah, and we talked about some common denominator risk factors, which definitely don't mean those people will, all shake a baby. But typically, like the younger and the more stressed for whatever reason, whether it's financial, maybe the child is very fussy or has an illness that's very demanding on the caregivers to care for, if there's drug or alcohol abuse, if they're a single caregiver so they don't have, any time or breaks for themselves, those add on to the stress, and so that could be a contributing factor. What about assessment findings for VP shunt malfunction? So first of all, what's a VP shunt? Yeah, ventriculoperitoneal shunt used to drain off extra cerebrospinal fluid when we have hydrocephalus. So what would indicate that it is not draining correctly? Yes, we would see increasing signs of intracranial pressure. And so hopefully we're seeing the early signs because we caught it early. But I guess it could continue long enough that it could, get worse and worse. So then teaching for the people going home and caring for someone who has a VP shunt would be based on what? Yeah, so y'all need to know the signs and symptoms so that you'd be able to teach them, so you'd be able to recognize them. And whether that's an early one, again, we always want to intervene when it's early on, and that way less damage has occurred. Okay, so bacterial meningitis, assessment findings.
Sore throat.
Fever, so potentially, yes, with fever, sensitivity to light, headache, vomiting,
Positive.
positive Kernicterus disease, that nuchal rigidity, or that, really holding the head still and guarding the neck movement is actually painful. Good. Okay, so priority nursing interventions for us. Oh, also, don't forget, we might see that petechial rash. So priority nursing inventions. We're inventing things now. We're all retiring.
Isolation.
Isolation precautions, what kind of isolation? Drop, yes. And then what are we going to do, and this would go along with our plan of care as well. So what are the things we're gonna do when we first establish that this, we're concerned this is meningitis? Yeah, we're gonna gather our cultures first, so blood culture, lumbar puncture for CSF culture. And then we'll start an IV and start administering broad spectrum antibiotics. We don't wanna put antibiotics on first, because then we start killing off our bacteria that we want to culture out. When our culture results, then we'll narrow down, like, whatever it says it's most, sensitive to, we'll go to that antibiotic. What if it comes back and says it's aseptic meningitis?
Switch it
Yes. So aseptic is the viral meningitis, so we would stop the antibiotics at that point, because that's not helping, and then we switch over to just, I know what you meant by comfort care, it's not like palliative care, it's like we provide supportive care and comfort while they work out that virus, yes. Yes, so controlling their pain with some, NSAIDs, potentially controlling fever with antipyretics, giving fluids if they're still having vomiting or nausea, we might have to keep the IV for some fluids, things like that. So what's our teaching for especially caregivers and close contacts now? Yeah, so if it was bacterial meningitis, everyone that was a close contact is gonna have prophylactic antibiotics. What about, how long does this kid have to stay on isolation precautions?
24 hours.
Yeah, so we've had to have broad spectrum antibiotics on board circulating for 24 hours, and then we can come off those precautions. We also wanna make sure that anyone who hasn't already been vaccinated, go ahead and, if they have an exposure, we'll go ahead and get them their meningococcal vaccination too, would be helpful. Okay, management of epilepsy. So generally, we have a couple ways we can manage it. What's the most frequent way we manage epilepsy? Medications. What's our most number one teaching about medications? Every day, yes, same med, same dose, same time, every day as prescribed. Don't stop it because you're feeling better, or you think you just wanna see what's gonna happen if you don't, or you go on vacation and leave your meds, none of that. But also, remember, we do have some alternative treatments that sometimes we use. We touched on like the vagal nerve stimulator. It doesn't do that for everything, but it does for some. And what about the ketogenic diet?
Even low carb.
Yes, high fats, lower protein, even lower carbs. So really, we're typically about 75 to 80% fats. It'll be prescribed. So that leaves about 15 to 20% in protein, and then just that little bee squid, that sad little pie plate on the graph for carbs. So just, y'all know what are in carbs, right? The sugars, all the best things. So if there are sugars in there, we have to be very careful about those in ketogenic. Okay, questions, because we've been doing this.
Stuff in here that you would compare, like this to this, then that could be put into a question like that.